Good morning, everyone. I hope you're all awake and have had your morning coffee and are ready and excited for day 2 of the conference. I know there are a lot of great speakers. I'm really excited to hear Dr. Al Poling this morning, and I hope that you are as well. I need to go over the same old announcements that you heard yesterday, but maybe you need a little reminder or refresher. The exhibit hall is open until 5 today. There is a special Around the World panel today at 4:30 that should be very interesting, and I encourage you all to go. It's 4:30 to 5:30 this afternoon. The children's play is Thursday at 3 o'clock. I'm not sure what room yet, but it will be really fun to watch that, and the kids work really hard to present that play. If anyone needs any help with Groupio app, I'm here, and David Roth is also here. If you need any help with any of those technological things or any other questions, we're here to help you. All right. Don't forget, at the end of the session, I will give the code. And for the social work CEUs, you have to sign in and out every day. So I get to introduce Dr. Al Poling. He is a professor of psychology at Western Michigan University. He received his Bachelor of Arts from Alderson Broaddus College, his Master of Arts from West Virginia University, and his PhD from the University of Minnesota. He's a fellow of the Association for Behavior Analysis, International Divisions 3, 25, and 28 of the American Psychological Association. Al has published 12 books and over 350 articles and book chapters, and served as the research advisor of 37 PhD recipients. So he's very busy. With them and other colleagues, Al has conducted research and done conceptual work in several areas, including behavioral pharmacology, clinical psychopharmacology with special emphasis on the effects of psychotropic drugs in people with autism spectrum disorder, applied behavior analysis, gender issues, animal welfare, quantitative analysis, learning processes, research methods, and scent detection. I was able to watch a presentation that Dr. Poling did a couple years ago at ABAI on the work that he did with poached rats and detecting explosive devices, and it's such interesting work and very, very helpful, I'm sure. So let's see. So Dr. Poling's work has been published in more than 50 different journals. He was recognized as a distinguished faculty scholar at Western Michigan University in 1999. In 2003, he received the Western Michigan University College of Arts and Sciences Outstanding Achievement in Research and Creative Activity Award. In 2016, he received a Lifetime Achievement Award from the California Association of Behavior Analysis, a Translational Research Award from the Association for Behavior Analysis International, and an International Humanitarian Award from the APA. So it is with my great pleasure to introduce Dr. Alan Poling. Thank you.
Thanks for the kind words. I appreciate it. I think from the introduction, it's clear that I've done a number of things, probably none particularly well. Honestly, I've always viewed myself as a teacher more than a researcher, so I've dabbled or done a little more than dabbled in a number of different areas, in large part because I could tell my students about things that I experienced firsthand, and also to give them opportunities to engage in activities that I found interesting, and sometimes they did as well. Now, pursuant to that, I need to give you an admission and perhaps an apology. I'm not a medical doctor. I'm an academic, and I'm going to talk about something that I can't do, at least not ethically and legally, and that is administering drugs to other people with the intent of improving their behavior in some regard. That's the domain of physicians, is it not? Medical doctors. It's not the domain of behavior analysts or anyone else, with a few exceptions. There are 5 states where psychologists who are properly trained can administer some drugs under special circumstances. But for the most part, when we're talking about the pharmacological treatment of people with autism, or anybody with any condition, we're entering the realm of medicine, and that's not my realm. So if anything I say appears to be critical of anyone, I'm not criticizing practicing physicians. Those individuals, for the most part, work hard. They do the best they can with the tools and training at their disposal. But if you think about it, despite the wondrous advances that we've seen in medicine, doctors, that is medical doctors, don't have a whole lot of different kinds of tools, do they? You know, think about when you've gone in to have anything treated. What does your physician do? Well, they sometimes do surgery, right? Sometimes they give you advice, but most of the time they give you drugs. Is that not so? I mean, now, they have a lot of different drugs they can use, right? They can give you a lot of different kinds of advice, but they typically aren't trained to provide advice that's especially useful in managing behavioral issues. It's just not part of medical school training. I mean, my heavens, they have enough to cover, do they not? You know? I mean, they don't learn, for instance, even the rudiments of behavior analysis in the vast majority of medical programs. And that's not a problem, right? We don't learn as behavior analysts or social workers or teachers how to interpret lipid panels, right? It's just not our domain. And similarly, medical doctors don't learn about the actual environmental variables that control behavior. So, and again, not being critical, the advice they give us is often not particularly useful, save as commonsensical, well, this is kind of a generally proper way to behave. So when you go to a physician with a behavioral challenge, whether it's your behavioral challenge or the behavioral challenge of someone in your care, your son, your daughter, that physician is likely to prescribe a medication. That's part and parcel of the practice of medicine. And of course, psychiatrists are specially trained to administer drugs to help deal with behavioral issues. In fact, until the mid-1950s, psychiatry was a laughingstock of medicine because psychiatrists didn't have much of anything they could do. You know, they could do Freudian psychotherapy. Well, that certainly didn't help people with many conditions, including autism. But in the early 1950s, a drug called chlorpromazine, trade name Thorazine, was introduced, and it really revolutionized the practice of psychiatry because chlorpromazine often produced substantial improvement in the behavior of people diagnosed with schizophrenia. In fact, at first, it looked like a panacea. It looked like it would help darn near everybody without producing any untoward effects. Well, we know now that's not true, but at the time, you know, this was the best thing since canned beer. And so now, physicians, psychiatrists in particular, have a tool they can use. And soon enough, a bunch of similar drugs, phenothiazines by name, were introduced, and the medicalization of psychiatry was taking form, and it's continued to this day. So if you go to a physician asking for help in managing a behavioral challenge, she or he's in all likelihood going to prescribe a medication. And they do so quite often. One reason that you're probably here is that I assume you work with people with autism who receive so-called psychotropic medications. Psychotropic medications, by definition, are drugs prescribed with the intent of improving mood, cognitive status, or overt behavior. And of course, the only way we know anything about mood or cognitive status is because people do something, right? So really, these are behavior change drugs. There are lots of them, and as I say, they're often used. Recently, two colleagues, Anita Lee, Crystal Earhart, and I have been writing some overviews of the topic I'm covering today, the use of medications to benefit people with autism, and we've perused the relevant literature. And in the last 10 years, there have been about a dozen studies published regarding the prevalence of psychotropic drug use in people with autism. And the figures yielded by those different studies vary quite a bit. The lowest prevalence we found was 26.5%, the highest 65%. I think kind of a good ballparkish figure is that overall something in the neighborhood of 40 to 60% of children and adolescents with autism receive one or more psychotropic drug. And of course, you shouldn't take my word for anything. Look at the relevant literature, right? Because people are wrong. I'm often wrong. I don't mean to be, but sometimes I am. So, to learn about anything, check the literature. And if you do, this is the kind of thing you'll find. Okay. Is this? Yeah. Should have checked this. Oh. No, I can just go back and forth. I don't have a whole lot of slides, so it won't be all that disruptive, I hope. But maybe if I fall, it'll keep you awake. So in a big study, 60,000 children, Mandel and his colleagues found that a little over half received at least one drug intended to improve their behavior. 20% used 3 or more. It's interesting they didn't report data for 2. I don't know why, but 3 or more, it's a lot of drugs. Similar results reported by Spencer and colleagues. A little higher prevalence, 64%, at least one drug. 35%, 2 or more. 15%, 3 or more. And that 35 and 15% are included in the 64%, obviously, or we have over 100%. So there's a lot of use of medications in the intent of improving behavior in children and adolescents with autism. And by the way, I'm saying autism so I don't have to wrestle with autism spectrum disorder. As you know, autism spectrum disorder, as currently defined in the Diagnostic and Statistical Manual of Mental Disorders, has 2 key features, 2 core symptoms. One is restricted, repetitive patterns of behavior, interests, or activities, and the other is pronounced and pervasive difficulties in interacting socially. Social communication and social interaction is impaired in people with autism spectrum disorder, and there are specific diagnostic features associated with those 2 core symptoms. But I'm just going to say autism. As you certainly know, autism is incredibly heterogeneous, is it not? People with autism very dramatic one from another. And that being the case, the challenges they face and the challenges we face in working with them vary substantially. But there are some commonalities, are there not? And we'll talk about some of those commonalities and how drugs are used in an attempt to deal with those issues. Now, we know less about how often older people with autism receive psychotropic drugs. And, of course, this is common. When you look at the research literature in any area, including applied behavior analysis, one might think that people with autism get well or go away when they're 21 years of age. Because, there are very few studies. We talk about applied behavior analysis as being really useful in treating people with autism, but that's based on studies of young people, is it not? Now, that's important. Early intervention is critical, no matter what you're dealing with. Start early, hit it hard. Don't let it get going. Life's about trajectory. you know? If you get something on a good path, even if it's moving upward slowly, eventually you go a heck of a long way in a positive direction. So yeah, early intervention, great stuff. But we know as well that people with autism have lifelong challenges. Many of them do, right? And somebody needs to address those challenges. And, you know, we haven't focused a lot of attention in that direction. I hope we do. And in doing that, we shouldn't turn resources away from early intervention programs. We should just garner more resources, which is easy to say, right? You know, it's like setting up a schedule to run a marathon. Well, you can set up the schedule. It's a lot easier than doing the training. So we don't know as much about prevalence in older people, but there have been some studies, and they show that prevalence is probably at least as high and maybe even higher in older people than in children and adolescents. Here's just one example, a study by Esbenson and colleagues published in 2009. It's an interesting study because it's a longitudinal study. Most of the prevalent studies are just samples of what's happening at one point in time. Often authors produce medical records, and they simply say, well, at time X of these 30,000 individuals, Y are receiving drugs. But here they follow the same people, not a large sample, like 286, for 4.5 years, which is really, really challenging. And they found, well, you can read here as well as I, probably better, that 70% were receiving one or more psychotropic drugs when their work began. And 4.5 years later, that number was up to 81%. I mean, 8 out of 10, right? What, pardon me?
The pharmaceutical companies are getting.
Yeah, exactly. Marketing got better over that period, right? That could well be it. By the way, if anyone has questions, comments, just join in at any point. I'm not going to talk to you for 3 hours. Don't worry about that.
Are these people all institutionalized?
No.
Where they're taking, or are they living at home?
It spans the gamut. Some of the studies look at people living at home. These people were fairly severely impaired. And one thing you find is that in general, if you look at who's receiving medications, people with diagnosed comorbidities, that is, other diagnosed psychiatric conditions like ADHD and anxiety disorder, depression, bipolar disorder, they're more likely to receive psychotropic medications. Also, people who are more severely impaired in general. You know, if you look at the DSM-5 ratings of severity, people who are rated as more severely impaired are more likely to receive drugs. And people who emit especially challenging behavior are the most likely people to be medicated. So if you have someone who's engaging in pernicious self-injury that is just almost impossible to manage, then in all likelihood that person's going to be receiving a lot of medication. The same thing with people who are assaultive and hard to manage. Yeah.
Could you tell me of those 286 people, were they spread across the country? What was the sample of?
You know, I think I remember, but I don't want to hazard that. I think it was a fairly restricted sample, though. It wasn't certainly a random sample. Yeah.
I think that's a great point that you're just making. I mean, as a psychologist, I'm just sitting here trying to recall if I ever made a medication referral for autism, but I haven't, right? I've made many referrals for comorbid anxiety problems, typically, right? I mean, that's, especially, and I've treated adults as well.
Yeah. Do we have any physicians here? Oh, excellent. Feel free to join in because you have.
Well, I would say I'm a pediatrician, and I'm the guy who prescribes all this stuff.
Okay.
And his point is spot on. I
Yeah.
don't treat autism.
Exactly.
I treat comorbidity.
Comorbid.
Of which we know there's a very high rate of comorbidity.
Exactly.
Kids with autistic spectrum disorder. they have both. And sometimes I have to treat both.
No, yeah,
And it's in concert with the behavioral management. It's not instead.
instead of, yeah, exactly, which I think is how it ought to be.
And you know, sometimes they have a tic disorder, so they need Clonidine too, and all kinds of things. So
Yeah.
it's amazing how quickly you can get up to 3 or 4.
No, exactly, yeah, yeah.
But anyway.
No, that, I think,
Get there.
yeah, and yeah.
As a psychologist with prescriptive privilege in one of those 5
Okay.
steps that you mentioned, I think that sometimes what happens is, or at least what I find is, just like you said, treating with medication and comorbids, and the push sometimes comes back from the funders that you can't write a prescription for X unless they have this diagnosis, and autism doesn't always have a medication schedule for that.
No, I mean, in fact, think about how we parse the behavioral stream, especially in medicine, right? We categorize patterns of behavior, and we call them diseases or disorders, right? Well, first we did that just to make sense of the world. We have to look at similarities and say, okay, well, these people are not exactly the same, but they have some features in common, and we'll call them X's. And these people differ substantially in their behavior, we'll call them Y's. And we can say, you know, this is a disorder, we'll give it a name, this is another disorder. So it helps us make sense of the world, but also the way money is allocated to medicine, if you don't have a diagnosis, you don't get paid in most cases. Is that not true? You know, I mean, and that's just reality, you know, and I see it as a problem with the medical system, but there are lots of problems with the medical system, and, you know, you can't blame individuals within that system for those problems. That's just the way of it. So there's a lot of use of medication, and as you might expect, just based on what little discussion we just had about treating comorbidities, if you look at the kinds of drugs that are used, the most prescribed drug class are antipsychotic drugs. And in the survey by Mandel et al. That I just presented, 31% of the prescriptions were for antipsychotic drugs. So they were the most used drug class. There are many specific agents in this broad category, which is typically divided into typical and atypical. The typical antipsychotics are the older drugs. The atypical are newer. Some people argue that the atypical antipsychotics are, in treating people with schizophrenia, more effective in alleviating the so-called negative symptoms, which involves not doing things that one ought to do. The data there are pretty weak. Some people argue that the typical side effect profile is milder with atypical antipsychotics. That may well be true, but all of these agents can produce some vexatious and even horrific effects. So they aren't all the same. And that really complicates things, because this is not an exhaustive list. I just put on all the agents that would fit with a font big enough for you to perhaps read it. Right? I mean, there are lots of them. And as I say, they aren't all the same. Yeah.
Our son is 19, severe autism, non-vocal, and takes naltrexone as of recently to reduce self-injurious behavior. We have maybe the data is not supporting a big change in the reduction of SIB, but I was wondering if you would be speaking to that class as well.
No, it's an opioid antagonist. So there are many other drugs that are used, and we'll get to that. Okay.
I think as important as what drugs you're using is what dosage you're using. I think a lot of autistic children need less. Our son's actually on 2 of those, but he takes a lower dose than most doctors would ever prescribe. And some of them are as needed. If he's really combative that day and I get hit 5 times, then I have the right to give him Trazodone. But I won't give it on a regular
I'll certainly defer to our physician on this, but my view has always been that in any area of medicine, less is more. You want to use a minimally effective dose. Now, it has to be the...
In autism particularly, the general wisdom is start low, go slow.
Yeah, exactly. Yep.
And because you start very, very low doses and go up very slowly, and it's quite easy to hit a tipping point and be too high.
Yeah, exactly.
You just generally treat them like you would old people.
Yeah, exactly. Yeah. So I think what's going on, did you say it was your son?
Yes.
Yeah, that strikes me as wise, And if a drug isn't producing benefit, the ideal dose is 0 milligrams per kilogram per day, right? If it's not producing benefit, then a person should be drug-free. But
Very much support our psychiatrist because he has given me full reign. Actually, he's also diagnosed with bipolar, which a lot of autistic have
Yeah.
dual
Yeah.
diagnosis. So once he's off his manic, I can just quit that drug.
Yeah.
And he has no problem with that, which I think is a really neat patient-doctor relationship.
Yeah.
I'm particularly interested in, and maybe you and I can talk more later, in what's being prescribed and what's helpful for the really aggressive behaviors, the self-injurious, some of the really aggressive behaviors in particular. My son is 6 and he's already dangerously out of control with throwing stuff and hitting stuff to the point where his older brother kind of moved in with my mom to get away from him. So, yeah, I'm hoping that we talk some about that. If you have anything.
Yeah. So another class of drugs that's commonly used to help people with autism are antidepressant drugs. And again, there are lots of them. And these drugs are typically classified by their neurochemical mechanism of action. So the acronym SSRI, as you probably know, is serotonin-specific reuptake inhibitors. So these drugs interfere with the inactivation of a neurotransmitter, specifically serotonin. And there are more than the ones I've listed, but again, just to have a reasonable font, I pick some. SNRIs, selective norepinephrine reuptake inhibitors. They work like the SSRIs, but instead of affecting serotonin, they affect another neurotransmitter, that's norepinephrine. And then there are a bunch of other antidepressants that don't have either of those mechanisms of action. There are also tricyclic antidepressants and monoamine oxidase inhibitors. They aren't so much used anymore, but they're still in the pharmacopoeia and they're used sometimes. So I just want to give you an idea that there are a bunch of these drugs. And again, as with the antipsychotics, they aren't all the same. So think about what a gargantuan challenge this poses for a physician. I mean, how in the heck, with all you have to do, would you know about the differences in these different drugs? No way anybody can, right? So physicians report typically that within each category, they have 1 or 2, maybe 3 drugs that they know well and use often. And that's a necessity. And the upside is they are familiar with these drugs, right? I mean, they know how to use them. They're guided by things they've done. On the other hand, that doesn't mean that these are necessarily the best drugs, right? But again, doing the best they can. Perfectly reasonable practice, right? Whoops. Not good at this quite yet. Stimulant drugs? Yeah.
I just wanted to make a comment about, first alongside participants before, where not knowing the right type of drug for certain especially ones with high intensity behaviors. It's important, obviously, to look at the dosages that they're prescribing, but also the way the body metabolizes the medication. So if the individual is not metabolizing it correctly, it's not going to be effective. So there's different tests you could do. We
Yeah, no, that's an excellent point. Like, these medications aren't metabolized in the same way by all people, and so they have different effects. And often it's not just the parent drug that is biologically active, that is the substance that a person ingests. The metabolites, the breakdown products, also can be biologically active. And if you have different degrees of metabolism or even fundamentally different pathways in different people, then you can get different drug effects. And in many areas of medicine, trying to individualize treatments based on physiology, which is in large part determined by genotype and also the activity of various genes, is becoming a really big deal. But you don't get this everywhere. You know, many medical facilities just don't have the wherewithal to offer this. In fact, in many parts of the country, it's hard to get medical care of any sort, is it not? Not just optimal medical care, but I have 2 kids, and they're older now. But when they were young, you know, sometimes just getting them in to see a pediatrician, you know, it was a challenge. I mean, it took a while, and you didn't necessarily see the person who might provide optimal services, you know. And when you did see someone, she or he had too much to do, you know.
You got to see them for about 7 minutes.
Yeah, you know, and that's not their fault. You know, more and more with managed care, people are pushed, you know, get them through. I had a general practitioner for years, and he retired early. He said, you know, I just can't provide good service anymore. You know, I'm constantly rushed. Get them through. People tell me what I can and cannot provide in terms of service, you know, or they won't pay. And this is the insurance company. So a lot's going on here. Now, the stimulant drugs, typically in psychiatry, are used to manage attention deficit hyperactivity disorder, ADHD. And 2 that you're undoubtedly aware of are methylphenidate, trade name Ritalin, and amphetamine. One of the trade names is Adderall. These drugs are widely prescribed. Now, they aren't prescribed to treat autism, right? When they're prescribed for a person with autism, they're prescribed to deal with symptoms indicative of ADHD. Now, there's a bit of an issue here, and that is diagnosing comorbid conditions in people with autism, right? Many of these people are not highly verbal, right? And psychiatric medical diagnosis depends in large part on verbal behavior, does it not? I mean, think about depression. How do you know when a friend or a loved one is depressed? Well, in part, you can tell by what they do and don't do, right? You know, their sleep patterns may be disturbed. They may not talk very much. They may cry. But we also rely on their verbal behavior, right? They tell us, you know. When I'm depressed, I tell everyone who'll listen, I'm low as a snake's ass. You know. But people with autism may or may not be able to say that, or for that matter, willing. But, yeah.
Well, our psychiatrist, and I'm extremely frustrated with the psychiatric care that we have right now, but he'll ask me questions like that, like, oh, does he have any suicidal ideation? I'm like, I don't know. He would, like, I'm not going to verbalize that even if he did. Like, can you ask me a question that makes sense?
Yep.
And so I don't even know where to go with it. Like, I know that something needs to happen, but...
Well, you know what? I mean, I don't know your psychiatrist, so I don't know how well she or he's doing what they do. But they're trying to find something to treat, right? I mean, they're trying to find some key, that a lock that they have might open, right? You know, well, is this depression? Well, then an antidepressant will be the way to go, right? But the problem is, it's hard to identify that lock.
I think it's what you said, is that what I'm looking for him to treat is autism, okay? Because right now the morbid diagnosis we have is ADHD, and that's being treated, but that's it. And there's a number of other behaviors that we continue to have an issue with, and because because he's not answering yes to the right questions or not getting any other options as far as medications, I think, so.
Yeah. You know, I think one thing to realize is autism isn't prophylactic for anything, right? It doesn't protect people from any of the other problems that everybody else can experience. You know, anxiety, depression, yada, yada, yada. The problem is just knowing what's going on when a person with autism is having challenges of one sort or another, right? I mean, you know, how do you divide the behavioral stream? Is this a part of the autism? You know, is this depression? Is this bipolar? You're not trying to isolate disease entities, are you? It's not like type 1 diabetes, right? With type 1 diabetes, there are symptoms, right? You know anyone with type 1 diabetes? What happened when they developed it? Do you remember? Extremely thirsty, copious urination, they get weak, they don't think well, and eventually they can pass out and die, right? You know, those are the symptoms, and they're evident in everyone with type 1 diabetes. But we know what causes those symptoms, do we not? You know, the beta cells in the pancreas are destroyed by the immune system. Those cells produce insulin. Insulin basically carries sugar into the cells where the cells use it as energy. Well, if you don't have insulin, sugar, glucose builds up in the body, and it causes all kinds of problems. And the copious urination results from the kidneys passing out this excess sugar in the urine, right? So there, we understand the disease process, right? I mean, we know the problems that result from a pathology. The pathologies, the autoimmune disease, the destruction of the beta cells, and the sequelae are the things we've talked about, and a lot of other things too, right? Well, here we have a handle for treatment, do we not? How do we treat type 1 diabetes? With insulin, right? We do replacement, you know, and it works pretty well, right? People with type 1 diabetes who manage food intake and insulin intake, you know, live relatively normal lives. You know, it's a bitch, hard to manage, but, you know, people do it, and they do fine. Do you have a question?
Some of these types of behaviors can be caused by other medications they're on too.
Yep.
My granddaughter, I have a past neighbor, she was on Stimulant for allergies for 4 years. And all of a sudden, she was getting really, really violent, trashing rooms, all kinds of stuff. And they went and put on the meds. And I read a thing online that if the child is on Stimulant for more than 2 years, it makes them at risk for committing suicide, for seriously hurting other people. I took her off the medicine and put her on Zyrtec instead. Within a week, the behavior stopped.
Yep.
Didn't use it for a year, had to use it again recently, and the behavior started right back up again.
Yeah.
So we're not going to use that.
Sure.
An allergy med can make them act out too.
Yeah. Medical problems that aren't psychiatric in nature, you know, can cause difficulties too. You know, if people are in pain, they behave in often troublesome ways, right? I mean, which is understandable. So, you know, a lot could be going on here, and it's hard to sort this out.
Moving thyroid too can mimic depression and.
Yeah. Yeah, so you need a good medical workup whenever you have behavioral issues. Now, no drug is approved for treating autism, but 2 drugs are specifically approved for treating a condition called irritability in people with autism. And to my way of thinking, this is perhaps bad business, but understandable. Have you heard the term irritability in your work? Irritability is a condition that is a label for a variety of undesired behaviors. And we'll talk about how it's typically diagnosed in due course. But the Food and Drug Administration has approved 2 drugs, risperidone, trade name Risperdal, and aripiprazole, trade name Abilify, for treating irritability. in people with autism between 6 and 17 years of age, so for young people. Now, what is this irritability? This disease? Yeah, this disease or disorder. How do you measure it? Well, this is what it is. It's almost always quantified by the Aberrant Behavior Checklist, which is a tool devised in the mid-'80s by Mike Amon and his colleagues for quantifying drug effects in people with what was then known as mental retardation. We now call it cognitive impairment, okay? And this is a rough and ready, easy-to-use scale. The most common form is the community version, which comprises 58 items. And someone who's familiar with the person who's to receive medication rates those items using this scale, okay? So we say injure self. Well, not at all a problem, which is a 0, all the way up to 3 is severe. And the rating is based on what's happened over the past month, right? So you see, this is easy to use. And psychometrically, this scale is reasonable. It's not great, but it's reasonable. Inter-observer, inter-rater agreements is pretty good. People have questioned the validity, but it's still generally accepted. These are the kinds of items. And the one marked with an asterisk indicate that this would be measuring irritability. The other items measure other things. And those other things are also given names. And these categories are based on a factor analysis of how the different items are scored by people. In factor analysis, you look at scores on different items, and you see which ones cluster together. And the ones that cluster together, and you do this with mathematical techniques, constitute a factor. So on the previous slides, those items demarked by an asterisk tend to yield similar scores. So if one item is scored high for person 1, the second item would also be scored high, the third item. If in another person, one was scored low, the others would also be scored low, right? And then with these other factors, they tend to cluster together, okay? So that's how Amon and his colleagues came up with what we now call irritability. They call it irritability, agitation, and crying, but people have pretty much dropped out everything except irritability. So that's how it's measured, right? And there's nothing wrong with it. I mean, this is a shorthand description of a variety of behaviors that are often exhibited by people with autism. And these are behavioral excesses, right? People doing something they ought not do that cause trouble. Cause trouble for the person who's behaving, lose them opportunities for reinforcement, right? Limit their freedom, so on. Interferes with acquiring desired behaviors. But these are also behaviors that cause trouble for caregivers. You know, it's horrible to see someone you care about hurt him or herself, or to engage in endless stereotypy. So these are things that we want changed. And grouping them together, that's okay. You know, it allows us to communicate. Yeah.
Than my 4-year-old, you know what I mean, like whine and cry. Also, is the self-interest behaviors, like my son banged his head, and now he's knocking on his head, but it's not irritability, it's attention-seeking behavior. Yeah. So how do they do that accurately? Because a lot of it, my son's what is really just young children's whiny, cryy behavior. He's tired, that's why he's flipping out,
Sure.
because he's nonverbal, versus it's irritability, and we can give you medicine to medicate this. And like, where do you draw the line there that, you know, this is just regular behavior?
I don't think there's a clear point of demarcation. You know, it depends in part on who's drawing the line, right? I mean, think about what constitutes a problem, right? I mean, people have different levels of tolerance, do they not? Even across cultures, you see differences, do you not? You know, my family has friends from different cultures, and, you know, in some places, like, the kids are expected to essentially be non-existent, right? You know, sit down, be quiet. Other places, the kids are rambunctious. So there is some variability here. Yeah.
I'll say it kind of depends on when it's getting in the way of your activities of daily living. Like, if it's getting in the way of him being able to function
Yeah.
in the classroom, if it's getting in the way of...
Say about everything, if it stops normal living, then it's a problem. But I mean, I'm just talking about it in this way.
Well-
Talking about.
But the same thing, like, I mean, when would we need to medicate it? When it gets in the way of other stuff? Like,
Yeah.
Well, the scale was based on your assessment of it, if it's a problem.
Yeah.
And so if it's not a problem for you, then it's who's doing the assessing on the scale.
Yeah.
Who's it a problem
For,
for?
yeah.
You mentioned like caregivers. Well, when you're dealing with a 4-year-old, you're the primary one that should be assessing.
Yeah, and that makes a really important point, right? What we're doing here is trying to change behaviors that are perceived by relevant people as problematic, right? And to some extent, it doesn't matter if you label these behaviors as irritability or not, except it's easy to reify irritability, is it not, to make it a thing?
sure.
How do we,
That's
so...
kind of the idea, though, isn't it?
Well, it seems to be, but how do we know that someone is exhibiting irritability? Because of how they behave, right? Well, okay, if you just see it as a shorthand summary, that's cool. But then you start to try to explain why the person is behaving that way, right? What do you say? So my son is hurting himself and throwing things, right? Well, those are problems, no doubt about that, right? And they need to be treated with drugs or in some other fashion. But why is he doing that? Well, often we can do a functional analysis or some other form of functional assessment and sort out the results of those behaviors. They're doing something to the environment, right? They're garnering attention. They're allowing the person to escape or avoid demands, right? That's why the person's doing it.
In general, every human behavior serves some purpose. If it didn't, we wouldn't continue to repeat
Yeah,
it.
I mean, people often, not always, but they often learn, for instance, to hurt themselves. Now, other times, it seems not to be so, right? There are no external consequences, or so-called automatic reinforcement, right? This sensory input somehow seems to be valued by the individual. But it's easy to fall into the disease model and say that my son is doing the undesired things he's doing because he has irritability, right? That it exists somehow apart from the behavior. Now, undoubtedly, something's different neurochemically when a person injures her or himself as opposed to when that's not happening, right? But we don't look for that when we talk about irritability, do we? So irritability isn't a disease, but the drug companies have made it a disease, basically.
I think it's a really important point that irritability is a symptom.
Exactly.
It's not a diagnosis.
Yep.
It's a symptom that can lead you to a diagnosis. But irritability can be caused by depression, it can be caused by anxiety, it can be caused by pain.
Yeah.
And you don't want to treat reflux, gastroesophageal reflux, with risperidone,
Right.
which I have inadvertently done before.
Yeah.
Because sometimes you can't figure out.
No,
You have
yeah.
a symptom in front of you, you don't know what the cause is. You make an educated guess, and sometimes you're wrong.
Yeah.
But I think it's really important, and I try and stress this to parents, that irritability, like inattention, are symptoms. It's not a diagnosis.
Not yeah.
And many things can cause that. We'll try and work it out together on what's
Yeah.
causing it.
You know, and I would say if you can sort out a function of a troublesome behavior, then probably the starting point should be trying to change that function, right? You know, if some troublesome behavior is learned, well, in principle, at least it can be unlearned. So, at least in theory, you ought not need a drug to deal with those problems. Now, that, again, that's easy to say, right? Not so easy to do. So, the aberrant behavior checklist is kind of okay as a rough and ready measure, but people who really know and care about behavioral assessment wouldn't applaud it, would they? It's not very precise. It's a Likert scale, right? You know, it yields just crude data. Yeah, you know, if person A is scoring 3.5 on average, person B 0.76, well, they're going to be very different in terms of their behavior. And that's meaningful to some extent, but it's not very precise. Also, these kinds of ratings can easily be biased, can they not? You know, imagine that you're a parent and your child is doing things that you really wish they weren't doing, right? Maybe you have a girl and she's hurting herself. Well, you want that to go away. Any parent would want that to happen. And you don't know how to help her. You've tried this, that, and the other, and now you're getting a script for risperidone, and you're looking for benefit, right? Well, it's easy to see change when there really isn't any. Confirmation bias is ubiquitous, is it not? You know, unless you're very careful, you can convince yourself that things are better when in fact they are no better. That's where data come in. Yeah, exactly. Now the ABC yields data, right?
Well,
but
even just for ourselves, before we go to a doctor, if we see something we don't like, we'll keep data for a week.
Yeah.
How often he's hit us, what happened before, what happened after, how we addressed it.
Yep. Yeah. See exactly. There you're doing a
If I'm in a really bad mood, or I shouldn't say really bad mood, but if I'm really tired at the end of the day and he hits me, it's more severe than if it's in front of me.
Sure.
I have a lot of energy, so I have to make sure I don't rate the one higher than the other.
Yeah. So if you're
It's
irritable.
very important to keep data before you meet a psychiatrist, a
Yeah.
doctor, a behavior specialist, or anybody, but complete data, and then after you have a drug, continue to do that, and that will verify whether the drug is actually helping.
Yeah, I say, you know, amen to that, right? You know, I mean, like if you're irritable, your son's irritable, right? If you're just rating it. And of course, it's easy to say you should collect fine-grained data of the sort that you're collecting, and it's wonderful that you can do that. But it's a challenge, is it not?
It is.
It's a huge
Because
challenge.
sometimes it's a challenge just to get through the day, let alone keep track of it.
Sure, yeah,
Like,
yeah.
I know, I absolutely agree with you.
But you know what you're doing.
Oh, I
Yeah.
agree, and I've done that, but when I think about, you know, I'm like, okay, so like I'm already dealing with all this stuff, let me pull out my chart real quick.
Yeah. Go, come.
What we're talking about shows the glaring problem between you have so many people helping with your child. You have a behavioralist that's awesome in helping, like my son gets new behaviors every 6 months. Like every six, you get one resolved and you found a good way to keep that one good, and he just develops a new one. And so like we just kept a behavioralist because we're just like, who knows what the next one's gonna be, and but like that's so like that's this person over here, and we have a psychiatrist that does medication for his ADHD, and you know it's like there's no like one person that kind of can see everything.
Yep.
You really do a really good job. So if that falls to the parents, and we're not educated in those fields, so we're trying to decide if a behavior is changeable because it's attention seeking, or he's tired, or whatever the issue is, and then, or is it something that requires drugs or a higher dose of medication because we go slow, like you said, they go slow. You know, does he need more medication? Is this dose working? It's very hard as the parent, being the person kind of on top, coordinating all these different things and trying to figure that out, and then also
You know, that is a
That's
key.
because you're the expert in your pit, though. Like they still only get like a pie slice of the whole picture. So.
And you just wish there was that collaboration.
You know, that's a key point. I want to come back to it later. We really need interdisciplinary teams. But like my granddad used to say, people in hell need ice water. You know, I said we need interdisciplinary teams, but my granddad used to say people in hell need ice water. You know, it's hard to get. Yeah.
I will say, like, in the school age setting, there are interdisciplinary teams, that you can utilize it. You have to, it depends on the county, it depends
Yeah.
on the, if you're from Pennsylvania, I'm not sure what the name is, but if you're from Pennsylvania and you contact your intermediate unit, interagency, that's what they do. Interagency coordinators actually coordinate all of the different agencies who work at the table. Yes, and we've had multiple meetings where we do pull the physicians, the psychiatrists, the behavioral, social workers, people coming through the house, the therapists, et cetera, all to the table to talk about some of these issues for kids that are falling through the cracks, or parents that need that overview and absolutely that case management.
Yeah, see, that's great there. I mean, people are going to get close to optimal care. Unfortunately, in my experience, that's pretty rare.
Well, it's rare if you don't push it.
Yeah, no, you do, yeah.
Like, you gotta be, parents don't even, and that's why we're trying to make it, and
Okay.
plus, in Pennsylvania also the system of care.
Why don't we hold off a little bit on discussion? I want to kind of wrap up this early bit, and then we can take a break and come back. So all of us know the benefits of using evidence-based treatments, right? I mean, it's kind of a sacred term, right? EBTs, yeah. You know, we do things that are scientifically validated. And of course, medicine was a discipline that really first got on the bandwagon with respect to evidence-based practices. You know, physicians know they should employ treatments that have been proven effective in sound studies. But there is debate as to what constitutes a sound study. In clinical psychopharmacology, checklists and rating scales like the ABC are widely accepted. And I would submit that they're not especially useful measures of behavior, but they are easy. And there's something to be said for that, because it's hard to collect good behavioral data. People with autism are a protected population. It's hard to do research with them. And there's very little money for researching drug effects in people with autism. So, you know, the studies are inevitably limited in various regards. So that being the case, it's unsurprising perhaps that these studies have a number of characteristic issues. So if you want to go to the research literature and pick drug treatments for people with autism, what do you find there, right? What's the quality of the evidence? Well, unfortunately, for the most part, the quality of the evidence leaves a lot to be desired. One problem is that outcome measures are weak. The aberrant behavior checklist isn't useless, but it's not really very strong. Another common measure of outcomes in drug studies of people with autism is the Clinical Global Impression Scale, which is really a piece of crap. I mean, it is, you know, like, and it's not just me that says that. If you look at what's been written about it, over and over and over again, people say this thing is not valid, it yields really poor inter-rater agreement. And yet, a review by Huffman and his associates of 115 studies of drug effects in people with autism found that 25%, a quarter of those studies, use that scale as an outcome measure, right? Well, you know, if you're not quantifying the effects of a treatment adequately, what can you say about that treatment? You know, It's like saying, how high can I jump? And if I can move my hand this far, I can jump 30 inches, right? If I move my hand that far, 48 vertical. Well, my God, Al can fly, right? You know? No, it's nonsense. And this is one problem with the literature. But there are a bunch of others. And again, I just listed as many as would fit on a slide with appropriate font. And what I'd like to do is take a little break now. How long do we need, do you think? 15 minutes, thereabouts, because it'll take a while to get somewhere. And then we'll come back and we'll pick it up again and we'll have some discussion. But that's enough for now. Thank you. A number of weaknesses that are characteristic of the literature in which the effects of psychotropic drugs are examined in people with autism. Now, you may say, well, I'm not a researcher. Why should I care about this? Well, the reason you should care is these studies provide justification for using drugs to benefit people with autism. And if the evidence is weak, then you can't know whether you're making a sound decision when you administer a drug. You're administering the drug based on hope, not on evidence. And that's okay. Sometimes that's all you have. But we know that evidence-based practices have a lot of virtues. And I'm going to talk a little bit about some of these weaknesses just to point out the implications of those weaknesses. No long-term studies. This is a big deal, is it not? Most of the drug studies last 2 months at most. People with autism frequently take drugs for decades. Some people with autism are medicated essentially from cradle to grave. And with many drugs, effects change over time. If you think about untoward effects, many antipsychotic drugs produce motor disturbances. They produce Parkinsonian-like side effects, and they produce tardive dyskinesias, like chewing, tongue thrust, that kind of thing. Well, the likelihood of those motor disturbances appearing with a given drug are directly related to how much drug a person takes per day and how long they've been taking it. So after 6 months, fine, no motor disturbances. After 6 years, could be a different story. Isn't always, right? But you can't detect those long-term effects if you don't conduct studies that last long enough to pick them up, right? But again, it's easy to say, well, yeah, let's do a study that lasts 100 years. How are you going to do that practically, right?
Any longitudinal study is difficult to do because you lose.
You lose participants. And if you think about what a scientist is trying to do, right? To be successful, you have to get research done, right? And although one 20-year study might be in some sense, in a clinical sense, a real feather in your cap, most likely when you submitted it for review, what you get mostly is crap. Well, you lost 2/3 of your participants, right? You didn't collect data for 6 months for person Y, right? So you can understand why there aren't such studies, but their absence creates a pretty serious hole, does it not? So what we have to do is ongoing surveillance of drug effects. By we, I mean physicians, right? So if they see that maybe a new drug's introduced that's being used for people with autism, seems to be pretty safe starting out, but a physician sees, hey, I'm seeing breast development in boys, right? Well, nobody knew this was going to happen, but it is. Well, we better report that, right? And now the FDA knows about it. It becomes a labeled side effect. That's okay, but, it's not as good as really having nice control research. not just of untoward effects, but also of benefit. You know, when we give a drug to a person, well, we want improvement here and now, but we also want lifelong change, do we not? You know, we hope that this person gets better and stays better. Well, the only way to know whether that happens is to monitor things over a long period. Weak data analysis, I'm not going to beat you to death with this. Some of it's a little esoteric, but one point is worth making. Statistical significance is not tantamount to clinical significance. In a lot of the drug studies, some measure of behavior is compared in a drug-treated group and a placebo-treated group. And if means are statistically different at some designated level, typically the O5 alpha level, then there's said to be a drug effect. Well, there's an effect, right? But does it amount to a hill of beans? Right? So if a person's self-injurious and hitting, in my case, himself, 1,000 times a day, well, if that goes down to 700 times a day, and that's a consistent change, that change is likely to be statistically significant. But I'm still hitting myself far too often, right? So we need measures of clinical significance, not just statistical significance. The experimental designs are often weak. You see a lot of so-called open-label trials where people who are rating behavior, monitoring performance, know whether the individual is or is not receiving drug. Confirmation bias damns those studies. You know. Now, why do people do them? Well, because often it's the best you can do. You know, this is hard research to conduct. It's ruinously hard. It's not that the people who do it are stupid, you know, or evil. They're doing the best they can. But still, this is a limitation. Inconsistent results, we'll talk about this later, but to say that a treatment is evidence-based, there needs to be some consistency in outcome. That's not to say that everyone treated for the same problem with the same intervention, whether it's a drug or something else, has to respond in precisely the same way. That never happens, does it? Never happens. But what you need to say is, in general, 6 of 10 people with certain characteristics exhibit benefit, right? Clinically significant benefit. Another 1 or 2 people show some improvement, but it really doesn't amount to a hill of beans. And 1 person doesn't change and 1 gets worse, or whatever, right? That's the kind of thing you want to be able to say. And you can't say it precisely that this works, you know, 78.116% of the time, but you can say the majority of treated individuals show improvement. But when you have utterly inconsistent results, you know, so one study shows no evidence of change, another shows great improvement, and a third shows inconsistent results, well, where do you hang your hat, right? You know, that nowhere. Little comparative research. Now, what kind of comparative? Well, comparisons of different drugs that could be used for the same condition, right? Think about self-injurious behavior. A bunch of different drugs have been used to treat self-injury. Opioid antagonists, naloxone, naltrexone have been used, antipsychotic drugs, alpha agonists, beta blockers. I mean, you know, just kind of pick your drug. But studies that do head-to-head comparisons, they're just not out there. So, you know, if there's some evidence, but it's weak, that 3 different drugs might be beneficial, well, what you'd like to know is which one is most likely to be beneficial, right? Well, you need comparative research, and there isn't any. Also, comparisons of pharmacological and non-pharmacological interventions. We know, for instance, that applied behavior analysis is useful in reducing irritability, right? Troublesome behaviors of various sorts. stereotypy, self-injury, physical assault, verbal assault, and so on, right? We know that. And we also know that risperidone is often useful for treating those kinds of issues, right? Well, how many studies would you guess have compared the two side by side? 0. Not one. Not one. Now imagine you're a parent of a person with autism who is self-injurious, and you've got it together. Like, you're looking at the literature, right? You're actively involved in your child's care, and you read all the studies. And so here are the behavior analytics studies saying, you can use this, that, or the other, excuse me, kind of a treatment, and it's likely to work. Not certain, but likely. And you have another body of literature, the medical literature, saying risperidone also is likely to work. Well, which is better? Hard to say, because the studies in the two domains, the behavior analytics studies and the medical studies, they're apples and oranges. The drug studies are going to be between group studies with statistical data analysis, large N. The behavior analytics studies are going to be small N, within subject repeated measures designs, right? With just graphic data analysis, probably social validation of outcomes. Well, how do you compare those? You can't, can you? There's no way to do that. So even the best informed person, whether it's a parent or a physician, or for that matter, a behavior analyst, can't be guided by data to say, well, this intervention's better. You just can't do it. The data aren't there. Combination therapies. Well, we know drugs are never enough, are they? Drugs don't teach people anything. Well, back in the 60s, they taught me a few things, but still, in general, right? We give drugs typically for what purpose? To reduce troublesome behaviors, right? Not to establish beneficial responses. But we know, as people go through life, the secret to happiness is to do things that pay off and that are deemed appropriate, and not to do things that cause difficulties for us, right? When you're raising a child, it doesn't matter if she or he has a diagnosis of autism or anything else. What we want to do is to teach them to do certain things and to not do other things. And there's a third category of behavior that's okay sometimes, not others. Masturbation, right? Well, it's okay in private, it's not okay in public. So we try to establish stimulus control. So to do those things, we need more than medications. But medications can sure help sometimes. They can render people sensitive to interventions that otherwise wouldn't be effective. If someone's just off the wall, just doing one thing over and over again, they don't contact consequences. You can't get them to emit the behaviors that you hope to reinforce. Well, drugs may render those people more sensitive. It's not a given, but it may well happen. But to know whether that's likely to happen, we need to look at combinations of treatments, do we not? And there are a few studies that have involving people with autism. And I don't want to go too far with this, but there's a suggestion, I think that's an appropriate word, there's a suggestion that combining behavior analytic treatments with pharmacological treatments sometimes maximize benefit.
We do addiction treatment.
Yeah, exactly. Yeah. Studies with people with ADHD and not comorbid autism suggest that sometimes you get more bang for your buck if you combine a stimulant medication with an environmental change kind of a manipulation. Now, of course, environmental manipulations aren't all the same, are they? We talk about applied behavior analysis is an evidence-based treatment for autism. Well, what aspect of applied behavior analysis, right? Do you ever think about that? I mean, applied behavior analysis is a discipline. It's not an intervention. So we have to be specific here, right? You know, what exactly are we combining with what? And again, hard to do. A few studies of drug combinations. We know that people with autism frequently receive multiple psychotropic drugs. And as we've talked, the reason for that is the alleged existence of comorbid conditions. So one drug is prescribed to deal with ADHD symptomatology, another to deal with anxiety and so forth. Well, logically that makes sense. And all else being equal, one, I believe, could rightly conclude that those drugs are about as likely to be beneficial in a person diagnosed with comorbid autism as in any other similar individual, right? I mean, there's, so far as I know, no reason to think that if a condition that we could properly call anxiety were present in a person with autism, she or he would respond differently to, say, a benzodiazepine than would a person who didn't have the diagnosis of autism. But we don't know that. There's really, no real evidence of that. And there are very few clinically relevant studies of drug combinations in people with autism. Anita Lee and I and a couple colleagues just reviewed drug studies that involve combining risperidone with another medication. And we found 13 studies. And surprisingly to us, a dozen of those studies were conducted in Iran. The Iranian researchers did this work. One study in the United States. The study in the United States was a case study. It was just kind of a retrospective, well, this drug was combined with risperidone and it seemed to help. You can't make anything of that, right? That's essentially an anecdote. The studies in Iran were more or less okay methodologically. They were double-blind, randomized group studies. The number of participants wasn't as large as you might like, but they weren't bad studies. But they weren't intended to look at drugs that are often combined in practice. Rather, they were designed to explore what might be neurochemical modulators of troublesome behavior in people with autism. So there's some reason to believe that oxidative stress may be involved in autism. So in one of the studies, they looked at the drug that might relieve some degree of oxidative stress. And that's the way the studies were done. So in terms of trying to get at neurochemical underpinnings, the studies were perhaps okay. I mean, they weren't perfect, but they weren't bad. But they don't tell us anything about what's happening when people actually receive polypharmacy, because they weren't looking at relevant combinations. So I think you can't conclude anything about the effects of these drug cocktails that are all too common. At the break, I spoke with some parents, and some of them have children who are receiving 2, 3, 4 medications. And one thing we discussed is, well, is this reasonable practice? And I always say, I can't tell you whether it's a reasonable practice. The only thing that can tell you that is sound evidence, right? You have to always ask, what do we want to happen here, right? If my son or daughter responds favorably to this drug, how exactly will she or he be different, right? And how can I tell that they are different? You have to measure something. And if a person clearly derives benefit from what seems to be an absurd drug combination that they can't receive in any other way, then I'd say, yeah, go for it. Evidence-based practice has 2 parts. And all too often when we talk about those practices, we forget the second part. The first part is a practitioner, whether a physician or special educator or behavior analyst or anybody else, should pick a treatment where there is evidence that it's likely to work to solve the challenge at hand, right? There should be scientific evidence that it's likely to work. But there is almost never an assurance it's going to work, right? Because always you have exceptions, or almost always. I mean, some treatments work well enough we can pretty much say, yeah, this is going to work. But not when you're dealing with psychiatric or behavioral issues. There, nothing works all the time. I mean, you've seen this, have you not? You deal with 3, 4, 5 people with autism. They seem to be having essentially the same challenges. You use the same strategy. You use differential reinforcement of alternative behavior, functional communication training. You do it the same way you always do it. And for some person, it doesn't work. Have you had that happen? I mean, if you live as long as I have, you'll have it happen, and I'm sure many of you have, right? I mean, we just never know for sure that we can change behavior with any tool that we pick, even if we know that we have a damn good tool. So the second part, and to me the more important part of evidence-based practice, is ensuring that each treated individual derives benefit, right? That's the crux of it. And even if an intervention isn't evidence-based, right? If it's clearly helping somebody, then you're justified in using it, are you not? The key always is evidence. Ask yourself, does the trip justify the fare, right? There's a cost. There's always a cost to any intervention, right? If nothing else, there's opportunity cost. While you're doing this intervention, you're not doing something else. So you say, well, what are the costs of this intervention and what are the benefits? And that holds for drug combinations, right? I mean, I would never say, that person A shouldn't take drugs 1, 2, and 3. I don't know that. But somebody needs to know that because they've collected relevant data. Again, though, easy to say, right? Parents and other people who provide care for people with autism have their hands full, do they not? When I first started consulting with families and teachers and so forth, I would ask people to collect data that I realized, having now been a parent, that there was no way in heck they could collect. So it won't take that long, right? Half hour a day. Well, they don't have a half hour a day. They don't have 10 minutes a day. You have to simplify your data collection as much as possible, right? Now, in principle, the data we collect, boom, in the everyday world should have the same characteristics as the data we collect in a scientific study. But we can't ever reach, or rarely, reach that degree of rigor. We just aim for it, right? So make sure your data are as meaningful as they can be. So if you look at the literature, it's not especially strong, right? So what can we conclude? Right? We're considering drugs as evidence-based practices for improving the lives of people with autism, right? So what can we say? Well, the first thing we can say, and we can say this with assurance, and this is no surprise. What the hell did I get there? Oh, I know what I want to do. I forgot something. Sorry. Because the research literature is relatively weak, experts often are cautious when they summarize the literature. And I picked an example of that. This is a good, or to my way of thinking, a really good review of the effects of serotonin-specific reuptake inhibitors as treatments for people with autism. And what I want you to see is the caution exhibited by these authors. So they looked at all the relevant research. They said, well, what conclusions does it support? I would read it to you, but I'd probably make a mistake. So look at how few studies there are. Can you read that? Can people in the back see this? Raise your hand when you've finished it, somebody, just so I... Most people finish with it. So, what are they saying basically? See, well, there's not too much here, right? I mean, there aren't a lot of studies. Some drugs have been studied a little bit more than others. Results are somewhat inconsistent. The studies are methodologically weak. So few conclusions are supported, right? And it's not that these reviewers have a vested interest in criticizing the literature. This is just their honest appraisal, right? So they say, there is no evidence of effective SSRIs in children and emerging evidence of harm. There is limited evidence of the effectiveness of SSRIs in adults from small studies in which risk of bias is unclear. Well, that's not much to justify the use of SSRIs. Yeah.
I just wanted to sort of add to what you're saying here about the
Wait. They're videoing this and they can't hear our questions.
Okay. About the severe limitations of what we're calling evidence-based. The only evidence that we have when we use these medications is that when the drug company did the study, it separated from placebo adequately enough for them to get the indication. That's all we know. And most of the time, when we're prescribing these medications for children, it's off-label. They don't have that indication. We're just guessing that it's going to work in kids. We don't have the studies for comparative studies of treatment modalities or head-to-head studies with medications because there's no money for that.
No, exactly.
The drug companies are not going to fund those studies because they don't want to have. Why should they?
Sure.
It could turn out that their medicine is not as good as somebody else's or other treatment modality. So those have to be funded publicly.
Yep.
And there's no money for it. Nobody wants to pay for it. So I think it's important for people to understand that I'm flying blind too.
Sure, yeah, no.
Because I'm guessing, and it's hopefully an educated guess, but it's a guess nonetheless.
No.
Doctor, what would be the study that you want?
Well, I would like to see, and there are academicians that would love to have comparative studies on which treatment modalities work best, and comparing treatment modalities. I mean, and comparing within those modalities, this medication versus this medication, or these combinations. But they have to be done strictly for the scientific knowledge,
yeah.
Not to gain an indication.
Yeah.
And I would say the vast majority of studies done on pharmacologic agents are done by the drug companies, and they are profit-driven. Period.
Yeah. No.
And this is the situation that we have, sadly. And I know I'm sounding like a socialist here, but I mean we really have to have some public funding for this. And this is a fairly strong group. Parents with kids with autism, and we should be pushing for this research. We really should.
You're spot on. Like, I agree with everything you said. There just isn't money to do this research. And so, as you say, we're all flying blind, are we not? Like we're all here because we want to help people with autism, every one of us. And we're trying to pick strategies that will work. But with medications, we just don't have the evidence that we need. So the one place we can get evidence is in treated individuals, right? It's not easy. But at least in principle, if person A is receiving whatever they're receiving, it doesn't have to be a drug, right? It can be a behavior analytic intervention, whatever it is. We, at least in principle, can sort out how they react to it, right? What do we want it to do? Is it doing that? And at what cost? That's, I think, where we all have to join hands and say, you know, let's not criticize things in general. We know the state of the research is abysmal. You know, it's not going to change quickly. I mean, I think the politics of the day are not going to support this kind of research. It's interesting. I've been in this business a long time, and when I started in clinical psychopharmacology, I was interested in drug effects in people with what was then called mental retardation. You know what pushed what little research was done? Lawsuits. None of you look old enough to remember White versus Stickney. Anybody remember that case? It was a case where back then there were lots of institutions. People with what was then called mental retardation in institutions received megadoses of typical antipsychotics, and they suffered irreparable harm. And people brought suit on their behalf, and that really got people looking at the effects of these medications. And the general conclusion was that although they benefited some people, in the vast majority of cases, they did no good and were likely to do harm. There wasn't a great deal of research, but there was some push for research. And practice has changed. People became much more cautious about prescribing the typical antipsychotics.
A question to quickly follow up on the push for evidence that you're advocating for now. Are there ways that we as parents, that we as practitioners within the field, what are actual steps we can be taking to push for that evidence? Because obviously we all really care about this. I would argue that there's so much money being spent on it that other people besides just us have to care about this too. I'm curious if maybe from a medical perspective and also from an academic perspective, if you have suggestions of things that we can be doing to compel this evidence to be done.
I think one thing we can do, just methodologically, is to rely more on small N studies, the kinds of studies that have been characteristic of applied behavior analysis, because it's really hard to do research with 500 people. But you might be able to do research with 3 people, right? You know, maybe you can accomplish a reasonably well-controlled drug trial using a within-subject reversal kind of a design. Difficult. I'm not saying that those studies are going to be easy to do, and they'll be very hard to fund because the medical profession has little use for those kinds of studies. But that may be a way forward. I've, and many other people as well, have for years said that the procedures characteristic of behavior analytic research are well adapted to medication evaluation. They aren't necessarily the best methods, but they may be the most practical methods. You know, so maybe that's a way forward. I think just advocacy. I mean, the same way we got insurance coverage for people with autism, right? I mean, you have to push, but you have to push differently. You know, but you know, try to get influential people on board. There's lots of people out there who'd like to do this research and could do it. But, you know, now, I mean, the truth is public funding is going down for all kinds of medical research. It's not going up. So this is going to be a hard road to hoe. Yeah.
Hi, thanks for this interesting talk. I just wanted to tag on to some of the things that folks up front were saying. Even if we had good evidence that these things work generally speaking, you made the point earlier that we still don't know if it's going to work for any one given child. So perhaps one practical strategy also would be for the physicians and the behavior analysts that are working with the children doing behavioral intervention could partner up a little bit to identify what would be relevant behaviors to track, what would be data collection systems we could use, and be able to report that back to the physician to make decisions jointly about what should be done. I've found that we've had the most success when we can establish that kind of relationship together.
Yeah, I think that's an excellent suggestion. The problem is we don't have that kind of contact most often. in the recent survey, Anita Lee and I asked BCBAs about their experiences regarding the use of medication in their clients. And almost all of them said their clients with autism receive medication. That's unsurprising. And we asked, well, how often do you work with a physician to, in any sense, evaluate medication effects? 20% of the people said that they did so regularly. 40% said that they worked with another person who had access to the physician, so typically a parent or guardian. But, you know, it's really easy to say we need these interdisciplinary teams. It's really hard to establish them, so that's an excellent point. And when they're in place, you know, one should thank one's lucky stars. When they aren't in place, one should work to get them put in place, but, you know, how do you do that?
Our behavior specialists and our psychiatrists are in the same agency.
Yeah.
And still don't have any communication.
Well,
in the same office location. They both work out of the same location.
yeah, I want to talk more about this in the next section, but, you know, one thing, medical people and behavior analysts often speak a different language. And sad to say, we behavior analysts often waste physicians' time. You know, I mean, they want a capsule summary. They don't have time to go over, you know, massive graphs and, you know, on this day that happened. Like, what in general happened? You know, that's what we need to do. But I think evaluation's key. You know, given our current state of knowledge or perhaps ignorance, you know, we really need to do a person-by-person evaluation as best we can do it. You know, I mean, sometimes our data are not going, heck, I say sometimes, almost all the time, our data are not going to be as robust as we'd like them to be. But still, if you don't collect data, then how do you manage your treatments? You manage by anecdote, do you not? That's what happens all the time. A parent goes in and talks to the physician. They may or may not even bring the person with autism with them. And if they do, her or his behavior is going to be different in the physician's office and in the natural environment. We know that. So watching the person with autism for 5 minutes doesn't tell the physician anything. They ask the parent or guardian, well, what's going on? Well, if something particularly bad happened since the last visit, right, then that may suggest a drug change or a dosage increase, right? Well, that's not a good summary. But we respond to stories, do we not? You know, and that's not a good way to manage any kind of a treatment, especially when we tend to see what we're looking for. Yeah. Oh, could we hand? Sorry. We want this to be a pretty presentation, and I'm not.
Talk loud.
There you go. I was just going to say that I'm not doing much for that, and if they focus the camera on you, we'll do better.
With the amazing ability that we have today with the internet for collecting evidence, and you're talking about it's the parents most often who do the evaluations. And I'm sitting here, and my background is as a journalist, as a computer person, as a mother of 2 children with autism. And I say, gosh, where's the graduate student who sets up an evaluation form that can be used by any of the researchers to evaluate different drugs? And then we who want to submit, and we who, I don't care about HIPAA violations here. You can know everything about me because I want to know about the research. I want to know what works. So share my information and give it to researchers. Gather it somewhere. Make a clearinghouse where you can submit your evidence using a form that somebody brilliant came up with and make it available to the people who can do the evaluation of the evidence to tell me what's working best for everyone.
You know, I think, you know, that kind of innovative thinking is what we need. You know, maybe that's the way to push the research forward. Make it cheaper, make it easier. It would be difficult to develop such a universal scale, but maybe not impossible, you know, a way to measure drug effects. those are the kinds of things I think that all of us concerned with helping people with autism ought to think about. Because you can wait, right? Well, wait till this study's done, wait till Yale gets involved or whatever. You may be waiting a lifetime. Now, even though the literature is certainly limited, it does support some conclusions in addition to the overarching one that no drug improves the core symptoms of autism. And I want just to share with you some summaries from some recent and generally good reviews. So there is some evidence that several drugs can produce short-term improvements in behavior. So as you'd be expecting, some value of risperidone and aripiprazole in treating irritability and hyperactivity. They claim that haloperidol, which is an old antipsychotic drug, is of some Haldol, is of some benefit. I don't know that most people would agree with that.
I don't know anybody that prescribed it to a child.
No, it's almost never. And these are old studies that suggest that. So, what do you make of that? A number of other compounds have acquired promising or preliminary evidence ratings. Well, okay, different reviewers reach somewhat different conclusions. So again, risperidone, aripiprazole may be of some value. Now, there may be a bit of bias going on here. These drugs are FDA approved, right? So on the face of it, that's prima facie evidence of effectiveness, is it not? In fact, in medicine, FDA approval is indicative of an evidence base for effectiveness, is it not? And as, I'm sorry, I didn't catch your name, but as our physician said, if you don't have FDA approval, it's off-label. That's the accepted part of medicine, right? But then you have to say, well, what other evidence do we have? If not the studies that led to FDA approval, are there any other studies that support effectiveness? Evidence also supports significant adverse effects of these medications. Always with any treatment, you have to ask yourself, what are the costs, the adverse effects? What are the benefits? And that's a difficult scale, is it not?
And I always want to know who writes these.
The reviews?
Yes. Is it a drug company? Is it somebody who is completely against drugs? Is it a neutral person that's doing the review?
Good point. That is.
The question is not who wrote it, but who funded it.
Well, the drug companies fund most of these studies. There are interesting things in this business. I don't want to be critical of anybody, but a lot of people of necessity are somewhat in the drug companies' pockets. Steve Hayes and I, some of you may have heard of Steve Hayes, we were going to try to do an edited book that simply summarized the effects of a whole bunch of psychotropic drugs across the board, not just in people with autism. And both he and I know quite a few clinical psychopharmacologists, so we were inviting people to write chapters. And we couldn't find enough. And a surprising number of people told us candidly that their funding comes from drug companies. And if they wrote an honest appraisal, they'd have trouble getting funds. That's tragic, is it not? But it's reality. And these aren't bad people, If they're in bed with the devil, they're in bed with the devil to serve God. Because they want to know what these drugs do, And they have to have money to do their research. And if NIH or NICHD is not providing funding, right? Well, they have to turn to the drug companies. They have no choice. They're not able to fund it out of pocket. So in saying what I just said, I'm not criticizing these people. What they say reflects their reality. But it's unfortunate. It's not the way to do optimal science. And I'd like to see our societal priorities shift. But, again, my granddad's maxim comes to mind.
I also think in doing a study like this, it's really hard because a lot of these, either they don't speak or they're echoing, like our son.
Yeah.
And our listed medication worked perfect about a year and a half ago. At that point, actually, his father, my husband, died of a brain tumor. Since then, his behaviors have gone really off the chart at times. So just looking at the data, they would say at this point it became non-effective. However, every time he has an outburst or something, he'll say, "Why doesn't Daddy come home?" Afterwards sometimes. So I think in reviewing all of this, you need to look at all the side effects because they're, even if they can't say it, they're highly susceptible to your emotions and to outside things that they can't talk about that somebody else will get off their chest other ways.
I don't know. She's been waiting so long. She's been very patient. Can't you see that irritability building?
Is it turned on? I just wanted to ask, do you know for a fact that no academic institutions are doing these studies? I mean, you've looked at all the studies that were completed. I mean, and this is not something that we just came up with today of being a problem. There must be a lot of people who looked at this as a problem and are doing studies.
There are people
and the other question is, the money that's raised for autism awareness, is that money going towards this at all, and why not?
Not to my knowledge. I think probably one reason is there are lots of important areas that need funding. And this may simply not be on the radar of people, I mean, there are people who are garnering funds, public funds, and doing this research, but it's ruinously difficult. I mean, there just isn't much money. If you look at the granting agencies, how much do they have in a particular pot? Well, if you look at the totality of funds available for autism research, there's not as much as you might think. And then if you slice that pie a little further, well, what of it might go to drug research? The slice gets small. I mean, it gets really small. These studies are incredibly expensive to do unless you do the small end stuff that I mentioned. And, the people who are doing drug research aren't trained to favor those kinds of studies. And they have some limitations. If you learn in a pharmacology class about a clinical study, it's large N, double-blind, placebo-control, and those are, and multi-site. You don't just do it here, right? I mean, you do it across the country. Well, once again, that's what we'll do, and I'll run a marathon tomorrow, It's not that easy.
I hope I articulate this clearly, but when I took this course, I thought that I'm the skeptic, because we're always so hesitant to give our child medication. She's young, but has a lot of doctors just immediately have gone there. But it sounds like we all have a reason to be the skeptic, because the data and the research that we're looking at is really not designed with, I don't know how, there's problems in the research. So when you go to your doctor and you're the parent, you've read something about, a gluten-free diet, dairy-free diet, and they go, well, that's not evidence-based. This isn't that much more evidence-based is what it sounds like. So now I'm starting to question, all those things that a doctor is telling me, oh, that's not evidence-based, because, gluten and dairy can't fund a study. Only the drug company can fund the study.
I think, I'm skeptical of everything.
Yeah. Well, that's what I'm realizing. You're the skeptic. It wasn't me who's the skeptic.
But one thing, make sure you don't let skepticism grade into cynicism. Yeah. Right?
The doctor can't, when you do come in with, one of these kind of, I don't know if crunchy is the right word, but a gluten-free, dairy-free study, or not study, but idea, and, there's parents out there, the research for for the ones that are evidence-based, there's not that much evidence, it seems like. So it's not that much of a difference.
Well, I mean, you know, sometimes there's evidence that something doesn't work.
Okay.
You know, and that's a different matter. You know, in autism, there are lots of garbage treatments that are touted as effective as miracles. There aren't any miracles. And sometimes when we look for a drug treatment for a problem exhibited by a person with autism, we're looking for a miracle. If we go to a physician and she or he recommends drug A and it doesn't work, we go back, help, they give drug B, they give drug C, and it doesn't work. Maybe the simple truth is there is no effective drug treatment. That's not the physician's fault. You know, but think about the demands we place on that physician, right? Help me, you know. Well, the physician's doing her or his level best, but as our physician says, they're often operating in a state of essential ignorance, right? They don't know what to do, and they're doing their level best, but sometimes they don't have a tool to do the job. At some point, those of us who are pushing for treatment need to say, there is no drug treatment for this problem. I'm sorry. As a culture, we have undue faith in medications, do we not? Because medicine has done miraculous things. I'm sure many of you know people who are alive today and doing well because of medicine. There's no doubt of that. But that doesn't mean that medical personnel can solve every problem in every person. And when it comes to changing behavior, you know, drugs are not necessarily the answer. I mean, there's a lot of criticism of the use of psychotropic drugs across the board. Like, antidepressants can be dangerous. There's very little evidence they produce long-term benefit in anybody, but yet they're widely used. You know, and again, that's not to say they don't produce miraculous or nearly miraculous benefits in some people. They do. But, you know, drugs are not panaceas. Yeah. Oh, listen. Do we have our... Sorry. Oh, thank you. Do we want to take another break? Just a quick one. We wouldn't have much time. Does anyone... If anyone needs to take a break, just walk out and come back.
Personally, I wanted to just mention first, I love that you mentioned Anita's work. I love both her and her partner as a prescribing psychologist and BCBAD. I think that we may have skipped over a bit that connecting part. It sounds like your providers and psychiatrists are in the same office, and part of the reason that there's not as much collaboration is because it's not billable. And so one way I think that parents and all of us, provider included, can get involved is saying we need to be funded for those collaborations. I know that we provide it, and my office manager often says, Dr. Tagg, stop doing that because it's not bringing in any money. And so I think that having more say in making sure that at least some of that is billable or is recognized, and then also, like you said, bringing the prescribing providers the material they need and maybe not the weeds, is really a way that we can help get involved and change that.
Why don't we press on? There are a few more things I want to cover, and then we'll come back and we'll have plenty of time for discussion. Does that make sense? Just so I can finish. So the reviews suggest, yeah, you know, there's some evidence that some drugs may be beneficial. But still, I think the vast majority of people who are knowledgeable with respect to the clinical psychopharmacology of autism are cautious. And I want to just show you some cautionary notes, give you kind of a sense of what people are saying. This is from quite some time ago. I present it not because it's dated, but because what they say is what people are still saying. Psychotropic drugs have only a minimal role to play. Drugs should be used sparingly and only when other strategies to reduce maladaptive behaviors have been properly tried. Makes sense. Would anybody disagree with this? Well, I mentioned that survey that Anita and I did, where we queried people with the BCBA regarding their interaction with medication evaluation and so on. What percentage of those people, would you guess, reported that in their clients, applied behavior analysis was used in an attempt to deal with a problem before medication? 20%? How many? 40%? 60? 80? 40%. 40%. Even though essentially all of those people said they thought that's how it should be. Well, as behavior analysts, that's unsurprising, right? You know, we think what we do is the way to go. Well, that doesn't mean anything, but you see here, these are not behavior analysts writing this review, right? These are clinical psychopharmacologists. But it's easy to say, well, we should institute a behavior analytic treatment. They're expensive, are they not? Always. They're hard to access. You know, in some parts of the country, they're very difficult to access. Dr. Stephanie Peterson, who's here with us today, has been doing a lot of good work on teleconsulting, you know, making an effort to reach out and provide behavior analytic services to people who can't directly interact with a good behavior analyst. Is that optimal? No. It's better than nothing, a heck of a lot better than nothing, right? But, you know, this is a reasonable recommendation. People aren't following it, not because they're stupid or ill-intentioned, you know, because they can't. And just a couple other recommendations, and then I'll shut up. So a little more recent. So I like the fact that they say we should use drug treatments when we have a serious problem that's refractory to change with other interventions. I like that kind of caution, right? So often people either say drugs are good or drugs are bad, and that's like saying rain is good or bad, right? You know, in a drought, rain's a blessing. In a flood, rain's a curse, right? You know, those kinds of simple-minded statements, they're just useless. The question is, who's being medicated, for what reason, and how are they responding? That's what it comes down to. But I think, yeah, pretty sound advice. The Center for Disease Control, a little longer recommendation, but in the same vein. So I like medication might help manage certain challenges, right? Might. That's the key word, not will, but might. It is important to work with a health care professional who has experience in treating children with ASD. I'd say experience is not the proper word. Expertise is the proper word, right? I have a lot of experience doing a number of things, and I'm not worth a hill of beans at it, right? I mean, seriously. Again, not to disparage physicians, but they aren't all the same, you know? And one thing that people can do to benefit individuals with autism in their charge is to share information about physicians who are good to work with. You know, now it might not be possible to access those physicians, but I mean, we have a gentleman with us today. I mean, obviously he's a reasonable person, right? He'd be a pleasure, I'm sure, to work with. Now you probably have a full caseload. I mean, seriously, you know. But work with good people. Make sure to closely monitor a child's progress and reactions. Be sure that any negative side effects do not outweigh the benefits. Well, I mean, that's kind of the mantra that I've been reciting. But again, you know, how do you scale side effects? Side effects often aren't here at this particular time. You're estimating what's going to happen down the road, right? Well, that's risky business, is it not? Especially given that some of the medications can produce really, really bad effects. I like to walk, I feel bounded here. In clinical practice of all sorts, do no harm is the first principle, is it not? And related to that dictum is follow the doctrine of the least restrictive alternative. In law, restrictivity relates to harmfulness. So if you have a number of interventions that might work in a given situation, you're obligated to begin with the intervention least likely to do harm, right? From that perspective, medications in general are restrictive because they all can produce untoward effects, and some are very restrictive. Now, they aren't all the same. Some medications are relatively benign. The odds of them doing anything that's seriously harmful is really low. Others, not so much. There's a substantial likelihood that they'll do some degree of harm. Some can even produce life-threatening side effects. But I think one ought to view the drug treatment of people with autism as a relatively restrictive practice in general, and then consider the individual agents separately with respect to potential harm. Consider, for example, risperidone. These are just some of the problems that you can see with risperidone. Again, I just listed as many as a slide would allow. You notice one thing that's absent here? Cognitive effects, right? You know, we don't know a lot about what these drugs do with respect to mental function, for lack of a better term. But this is enough, is it not? You know, not to say that the benefits of risperidone wouldn't outweigh any or all of these untoward effects. They might, but they might not. And so this is an issue that needs to be appraised carefully. Autism Speaks has a nice set of materials for parents or other caregivers to help them evaluate whether or not a drug trial is appropriate. Have any of you looked at that material? You know, I mean, it's not perfect, it's pretty good, isn't it? You know, at least it gets you thinking about the right things. Because I don't know about you, but I like to go to my doctor, my physician, and put things in this case, her hands. You know, like I'm not an expert. Just, heck, help me, right? You know, if this is wrong or that's wrong, make it right, you know? And my physician would, I'm sure, like to do that. But she may not be able to. So we need to get involved in the care that anybody provides for the people that matter to us. And the Autism Speaks tool is I think, pretty valuable in helping us make sure that the people we care about who might receive a psychotropic medication are likely to benefit from it. Now, in doing all this, I think it's good to keep in mind the quintessence of appropriate treatment in any modality, it doesn't matter. You know, are you talking about drug treatments? Are you talking about surgery? Are you talking about applied behavior analysis? Here, drug treatment, but you could substitute any other treatment for that. Because drugs are relatively restrictive, you probably want to have a good reason to think that they're going to work. Now, often you just don't know. So, you know, take your best guess. The second thing is always important whenever we do anything with the intent of helping somebody. The goals have to be clear and in the treated person's best interest. Often, historically, drugs have been prescribed not for the benefit of the people who receive them, but for direct care staff. There were horror stories regarding the use of huge doses of antipsychotics in institutions to basically turn people with mental retardation into furniture. So these people didn't cause any problems. They couldn't move. I exaggerate only slightly. That's not good treatment. Now, everybody knows that. And fortunately, those kinds of clear abuses are essentially gone today. I don't think that that's happening at all. But it's easy to not look at the world from the perspective of the behaving individual, you know? So I'm flopping on the floor and having tantrums now and again. Well, that would create problems for my family, right? But it might make my life better. Maybe that's the only way my wife and kids attend to me, right? I mean, seriously, you know, it's not that bad yet, but it could be, right? I get a little older and uglier and meaner, you know? Who knows? But, you know, we do have to think about those things, you know? Like, why are these behaviors occurring? Why is a person doing something that they, from our perspective, ought not do? Well, often they're doing it because, in some sense, it arguably makes their world better. It gets access to something that they couldn't otherwise get. Or it removes or prevents interacting with something that's unpleasant, you know? So look at it from the treated individual's perspective. And if you take something away, add something in, right? You know, maybe if we do a functional assessment and we sort out that some troublesome behavior, self-injury, is attention maintained, well, instead of using a medication, why don't you try a differential reinforcement of alternative behavior strategy, right? Arrange extinction, if you can, for the self-injurious behavior, and teach the person some other appropriate way to get attention, right? I mean, in that case, you don't need a medication. So, you know, look at it from the to-be-treated person's perspective, which often involves a functional assessment, sorting out, you know, why is this behavior occurring? For me, behavior analysis is all about looking at relations between environmental inputs and behavioral outputs, right? What's happening in the world? How's that affecting what a person does? And if we can isolate powerful relations between environmental inputs and behavioral outputs, like in the example I just gave, when does a person get attention? Only when they flop on the floor, right? What's that do? Makes it likely they're going to flop on the floor, right? Well, when you know that, then you can proceed rationally to develop a treatment. 3, and we've beaten this horse to death, so I won't say much about it, but make sure your treatment decisions are made on the basis of real drug effects, not on the basis of hope. Hope is reason's greatest enemy, is it not? You know? When a person that we love has problems, we want them to get better. And we look for evidence that what we're doing with the intent of helping them is accomplishing that goal. but we can easily be deluded. There's no doubt of that. So that's where collecting real data come in. The fourth thing, and again, this is the thing we've broached, ensure that drug therapy is flexible and integrated with other interventions. We really, really, really need interdisciplinary input to maximize gain in people with autism. But like so many good things, it's expensive, you know? And our societal priorities in their totality don't support interdisciplinary teaming. You know, I think the autism advocacy community needs to band together, you know, and argue for this. You know, try to get people to support it. Now, you know, I don't do that kind of work. I really don't have any practical suggestions, but I know people have been hugely successful. I mean, think about how much better things are today for people with autism than they were 20 years ago. You know, the range of services that are available and the depth and breadth of services is wondrous relative to what was available 2 decades ago. There's no reason that momentum can't carry forward and provide more interdisciplinary teaming. Better training for everybody involved. Remember the CDC recommendation, make sure you get a good physician, an experienced physician. Well, it's interesting that most primary care physicians That's okay, I can tell the story. Most primary care physicians report that they aren't comfortable providing services for people with autism. They feel that they need more training and that the services they provide are suboptimal simply because they don't know how to provide better services. And that's not to disparage them. I mean, that kind of candor is remarkable. But it's hard to find good team members. And if you find them, it's hard to pay them so that they come on board. I mean, people can't work for free. You know, nobody can do that. But what we need is something tantamount to the IEP planning sessions that we have in schools, right? Where we get a whole bunch of relevant parties involved, and they sit down around the table and they say, okay, you know, what would benefit this student? And how do we attain that benefit? You know, you do this, you're the speech pathologist, you work on this, you're the special ed teacher, you work on that, I'm the regular ed teacher, I'll work on something else, you know, we got a behavior analyst, she's going to do a fourth thing. That's how I think we maximize bang for our buck, but with medications, we just aren't there yet. And we often ask our physicians to work in what is essentially isolation, you know? They don't have a window into the everyday world of the person that's receiving treatment. And so it's very difficult for them. And I think at minimum what we can do, especially as parents or guardians, is to talk with the physician and ask, well, you know, what kind of data would help you make treatment decisions? What information could I provide? And in what form would you like that? And at least as a starting point, I think that's a good one. Well, that's enough for my rambling on about this topic. Why don't we just throw things up? Oh, go ahead.
I want to address collaboration, if I could.
Sure.
Reimbursement, of course, is a big factor. When I go to a school and I attend an IEP for an hour, obviously I don't get reimbursed for that.
Right.
But it's very valuable because I can see in that setting how my medication is helping this child. I can get feedback. I can talk to the school and let them know what my plan is. And then the teachers will call me.
Sure, yeah.
And it's extremely valuable. I have yet to get a call in all these years from one behavioral specialist taking care of any of my kids with autism. They won't, I don't even get phone calls. And it's not like I've said, don't call me.
Yeah.
So they could at least, it's
Make
like
the
my
effort.
mother would say, you could at least call.
Yeah.
Right. So I think it goes both ways.
Sure, no,
I
yeah.
I would love to talk to these people and see what's going on, rather than go through the filter of the parent, which is, it's sincere but skewed. So that's one thing. I mean, not only the reimbursement, but the will has to be there. I've had one behavioral specialist call me, but she's my daughter.
Oh. And that's at Christmas, right?
Right. Yeah. So I think that we have to start by making that effort. And please, the reports that I get are huge. And full of jargon. I get nothing out of them. I look at them, I initial it, and it gets filed. Yeah. I won't read it.
No.
Call me. Talk to me.
Yeah.
I don't understand your reports, and I don't want to spend the time reading them.
Yeah,
I don't have that time.
No, amen to that.
Okay.
You get a little workout here.
He is. If you don't, I'm not trying to stir the pot, and if you don't want to address my question, that's fine. But where does cannabis fall into all of this?
Nobody knows, I think, I mean, I don't say that lightly. I mean, I think that's just the truth. And I think there'll be huge barriers to ever knowing anything. Yeah,
Yeah, just reflecting on the discussion today, I've heard a number of problem statements. Doctor, you presented a few problem statements in your presentation, and we've heard additional ones from pediatrician, from service providers, from parents. We've talked about advocacy, we've talked about data collection, potential solutions to these problems, but to me, these are symptoms of something greater. I don't see a root cause. It's not clear to me, or a root cause is. And in your analysis of the problems that we have and the work that your team has done, have you taken it to that level? Have you driven it down and asked why? Why do these things exist? And are you willing to share that with us today if you have?
Well, only at one level of analysis. The only way I've construed the causes of these behavioral challenges is in terms of environmental variables, not in terms of genetics or neurochemistry. But there are lots of talented people trying to sort out what's different structurally and functionally in the central nervous system of people with autism and other people. There's no doubt that things are different, and people are getting some notions of it. I don't typically talk about that because I don't have any expertise, and in fact, as best I can ascertain, nobody really knows. They're getting closer. But if we ever do understand what we might call the disease process, then there's a potential for some real rational pharmacotherapies. But we aren't there yet. Maybe someday, I'm not confident in it, but maybe someday there actually will be a drug that is valuable in reducing the core symptoms of autism. If we knew what caused those symptoms, and if it was relatively simple and amenable to change with a drug, then that would be wondrous, would it not? Maybe someday there'll be an insulin for autism. I'm not confident of that because it's my notion that whatever is different is complex and multifaceted. But who knows? I mean, think about genetic engineering, some of the things that are going on. I'm no expert there, but I was going to say great stuff. It's not always great, powerful stuff that's being done. Like we can change things in ways we never could before. And maybe, in the not too far distant future in your lifetimes, maybe we can intervene at a different level. And, I, for one, would like to see that happen. I'd be delighted if there was no need for behavior analysts Well, not really, because I need a job. But seriously, you know, if we could intervene at the causal level, well, that would be great. But we just aren't there yet.
We have a 3-year-old who was nonverbal, and we did a trial period with Ritalin, and it did unlock his vocabulary, which was, to me, a miracle. But then it also caused much more severe stimming visually and lack of appetite. So we did end up having to take him off of that, and he did not show any regression, which was our biggest fear. But as the reason why I came to this particular, it was scary. All this stuff is so scary to a parent, and considering putting our child into a drug trial, it's scary. How do we even consider it? You know, I mean, the benefits can outweigh the negatives. However, it's a trial for a reason. So, I mean, I can understand why there aren't these but do you have any words of encouragement for that?
Well, yeah. I mean, I think the way to proceed is just like you did, right? I mean, you have a good reason for medication, and you watched very carefully, right? You saw benefit, but you saw costs were outweighing the benefits, so you stopped. But the benefits continued. Well, I mean, that's a good deal, is it not? I mean, I think that's the logical way to proceed. You start a drug trial with a clear goal in mind, right? You also are willing to terminate it if that goal is not accomplished, or even if it is accomplished at too great a cost. Then you minimize risk of harm, you maximize risk of gain. I mean, I think that's the logical, ethical way to proceed. And even if your son or daughter is a participant in a research trial, they can drop out at any point, right? You know? So typically, were a person in your care to be in such a trial, you won't know if they're receiving active drug or placebo. But if you see that something bad's happening, well, end it, right? End it. I mean, you know, that's, I think, the way to proceed. Do we?
I have the mic here.
Okay.
I just wanted to say that I am a sibling and an advocate for my brother on the spectrum. Also have been a teacher for decades, and now I am a consultant. And so I've been sort of on all sides of this, and the one piece that I really see missing in the collaboration piece is with the school. And when you talk about the IEP model, and the doctor talked about going into the school, I can't tell you how valuable that is. I feel that, you know, in my time of teaching, I had, and like I say, decades, one doctor or one psychiatrist ever come into my class, stayed for 5 minutes, and gave a misdiagnosis of a deaf and blind child as autistic without talking to me, without talking to the parent, and prescribed programming and medical treatment. And so I feel that it's really imperative that parents talk to the school. A lot of times when we go in as consultants for the school, and you know, and also dealing with, you know, admins, school teachers, parents, a lot of times teachers will tell us that parents don't tell them about medication changes. And when I talk to parents, the family piece, sometimes parents tell me they want to sort of present this tabula rasa. They want a blank slate. They don't want to color or stigmatize, you know, or bias, you know, educators that are working with their child. And while I understand that, it's really helpful for side effects alone for educators to know.
It's like winning the lottery.
So I do want to say one thing in defense of drug companies, but it'll only be one, I promise. But I think this has to be recognized that many times, I'm not going to say most because I haven't had that experience, but many times in their trials, they do use commercially available outcome or rating measures that they don't develop. So, but that's an important point to recognize because that obviously determines what the outcomes are. Now, I could give you, so I work in the test publishing industry. I mean, I'm a psychologist, but I make tests, okay? And we could have a course on why you need to use rating scales with caution. And I'll tell you really in-depth reasons why. But I do think that that's an important point to recognize. But with that said, as a psychologist who also provides treatment, every treatment occurrence is a single study design. And that's, you had alluded to that earlier, and that's really what it's all about. But I did want to say that because, you know, the drug companies still have a burden of evidence that they have to demonstrate. And so they don't make their own rating scales to measure the effectiveness of their drugs.
Yeah, exactly.
So, I mean, I just want to point that out.
Yeah, and the other thing...
But that's only the good thing I'll say.
The drug companies aren't inherently evil, you know? I mean, you just have to look at the work that's been done and take it for what it's worth.
And to the physician that the behavior specialists aren't giving you a call. I am a behavior specialist, and as we talked earlier, you go into a doctor's office, and more times than not, they've got 5.2 seconds to spend with you. I do attend drug medicine updates with one of my consumers, and the doctor could care less what I have to say. And it's a rare occasion when we find a physician that wants to hear anything that we have to say. And more times than not, to talk that through, you need more than, you know, the 5-10 minutes that are typically available, you know, for that purpose, because it's a collaboration, and that collaboration doesn't happen in 15 minutes.
No, I think that's often true. The question is, what can we do about it? You know, because physicians just don't have much time. And also the FERPA regulations, you know, like you have to get permission to hear about people's medical condition. You know, so, you know, I mean, you know, I have to get permission to hear about my daughter's medical condition just because she's now a legal adult. You know, so well-intentioned people who care about Jessie, my daughter, you know, they can't provide input or get information unless we go through, you know, the rigmarole of allowing them to do so. You know, now, you know, I can do that, my wife can do that because, you know, we're educated people, reasonably affluent. But a lot of families who are caring for people with autism have a lot of challenges. You know, I mean, caring for any child's hard, and caring for a child with autism is especially difficult. So, you know, to expect people to do all that's necessary as parents or guardians to start getting these teams in place, I think is unrealistic, and yet they're the only people with the legal status to do so. So, I mean, I don't know where that leaves us.
I just have a quick comment. And like I'm a parent of an autistic child who's 9. My life is chaos. And I appreciate like everybody who takes their time out of their schedule to attend conferences like this. Ultimately, it is me that is the liaison, the advocate, the one fighting for my son. And I'm totally impressed you go to IEP meetings. I know my pediatrician would love to and has the heart to do that. I have not asked her, but it is ultimately up to me, even though I'm super busy, but everyone's busy. You're busy, everybody's busy, but I'm the one who has to be number one for Team NOAA. So I have to bring the information from the pediatrician, from all the people on NOAA's team, the school, the behavior therapist, everybody, even his therapeutic writing. But I just feel it, and I know it's hard for parents because it's hard for me, but I'm the one who's going to do it because he's my son. So that was just my comment. I think it's just ultimately the parent has to do it.
Yeah, you know, and it's a great credit to you that you do it. It's difficult, you know, and the way things are configured today, the role of integrator, the role of advocate, it falls to the parents. And they've borne that burden wondrously, but they need help. And I think that's where we professionals need as best we can to push things forward and not to be critical of one another. Like so often when I talk with behavior analysts, they say drugs are bad and physicians are evil. Well, I mean, they do. And it's like, come on, you know, neither of those things are true. Now, there was one thing that I found interesting and perhaps heartening in that survey that Anita and I did. We asked the BCBA people, do your clients who receive medications often or always benefit from the drugs? 65% said yes. You know, so drugs are doing some good, you know. Yeah, you know, they aren't. I mean, doctors do the best they can with what's available to them, with the time they have, the training they have, and the system within which they operate. You know, and we can't, well, I was going to say demand miracles of them. We can demand them, but we can't expect them. They would gladly provide them if they could.
I'm a parent of a 35-year-old, so he wasn't even diagnosed until his 20s because it wasn't even an issue until he was in his 20s. So all these supports that are there when the child is young is just great, and you take advantage of all of those and the physicians that help. Pennsylvania has an autism waiver for adults, which has a very limited amount of spaces. We waited 4 years to get on it. There's people still waiting. They're trying to expand that, but that's a great way that Pennsylvania is trying to move ahead and still take care of people with autism. But you're still the parent, you're still the coordinator, you're still jumping from psychiatrist to doctor to CIs and people that are working with your son or daughter. So that never ends, and it's scary to think you have an end. What's going to happen to them after that? So this Pennsylvania autism waiver has been a blessing to us because it's a carry-on of those services.
Hi, I'm going to be doing a talk on the same subject on Thursday morning, and you've covered a lot of some of what I was going to talk about, but I'm going to be speaking more to the behavior analysts in the group and what you can do to get involved in this context. So all I'm going to say here is the behavior analysts you have to attend, for the behavior analysts in here, you have to attend these meetings if you can. You've got to get a release to be able to get medical records and to be able to talk to the doctor. You have to go to the meetings if you can, if the parent will allow you. And you have to go in there realizing you're not on equal footing with the doctor. We got to get over ourselves here. The point is that you're there to help the doctor collect information that they need. We're supposed to be experts in successive approximation and shaping, right? We're supposed to be able to build these types of relationships with people. We go in there and say to the doctor, what do you need? What data can I get to you? If it's sleep data, fine, you get that data. If it's eating data, fine, you get that data. But you don't do this by email. As you said, you call the doctor if you can, you talk to them. The release is key. But going in there without the attitude that you know a lot of stuff and you're there to bring the doctor what they need to do, that's not going to work. The point is bring them what they want. Right, and build a relationship, and then over time you can start to bring more behavioral data and whatever. That's basically all I want to say in this context. But that's key. It's how we approach this.
Yeah, that's spot on. And I think finding a physician who's amenable to this sort of an approach. You know, not everybody will be, but some certainly are.
Hi, I just have a quick question. What do you think, what do you know about stem cell therapies, and what do you think about the recent research that's been done with stem cell therapies, like, for example, Duke University study?
You know, I'm no expert. All I can say is it looks promising. You know, and I hope it is, but that's as far as I could go safely. Does anyone else know more about that? No, I'm sorry. But
I just wanted to remind everybody, because sometimes we think of it as autism and we don't think of it as children. My family doctor put my granddaughter on this on whatever that is. I left her on it for 3 days. She couldn't put 2 words together. She was jumping on the couch. She was sleeping an hour a night, and I took her off it. I'm not willing to put her through something like that and then expect her to go to school the next day and not get in trouble for acting out. They're not guinea pigs. You know, remember, they're children, and they've got to function, and they already know they're different. So be careful what you put them through.
Yeah, I mean, I think that's a good point. And not just with drugs, with everything else. You know, I mean, there are horrid interventions that some people advocate. Yeah, you know, well, wrapping them in blankets and, you know, essentially half smothering them, those kinds of things. It's all well-intentioned, but, you know, not so good an outcome.
I'm a foster parent slash grandparent of a special needs little boy. And going off of what she said about remembering their children. I listened to a lot of this talk today, and it's really great information, keeping in mind that they are children. And I think of my grandson, and I say, you know, I know other people, we go in public, there's issues, people look at you a certain way, they make judgments. I usually respond with, if you're not going to be part of the solution, don't be part of my problem. Keep walking. Gotten very verbal about that. I don't limit taking him in public. We took him to Disney World. We take him out. We include him in life. I think sometimes we have to remember not just trying to fit them into our world. How do we fit into their world?
Good
because
point.
My grandson makes me a better person every day. So.
You know, that's an excellent observation. Like, it's so easy to have a mold that we try to fit everybody into, and not everybody fits into that mold regardless of whether they have a diagnosis of autism or anything else. And sometimes I think what we need to do is, you know, try to change something that is clearly vexatious, causing some problems for the person. But then at some point you say, no, that's who she or he is, you know? And we're going to deal with this. Like, we're not going to do any more drug treatment. We're not going to do any more ABA. I'm not talking about something like self-injury, but, you know, self-stim, you know, some other things. Let it be. Let it be, you know. Change the world to make that acceptable.
Just as a follow-up to that, I was going to come find you when you were speaking a little bit, but I think everybody could probably benefit from this book. There's a book called Uniquely Human. I heard it mentioned yesterday. I don't know which talk I was in, but it's an excellent book, and it looks at autism a different way, kind of like what you said, like, I'm not going to worry about eliminating the stim, but rather ask why, and what does that do for the person? And the author actually calls things like when a kid focuses heavily on something, rather than trying to crush that out of the person, look at it as an enthusiasm, and he calls them like his enthusiasms instead of a stem. And that book really changed my perspective on how I deal with my Sadie, because I just want to give her a good life. Her life's going to look different, and that's okay. I just want her to have a full and happy one. So that book really helped me.
You know, the truth is all of our lives look different if we have a powerful enough microscope. Why don't we do one more and we're out of time. If anybody wants to chat with me, I'll be around. Also, if there's anything I could do remotely, feel free to email me. My email is just my name. It's alan.boling@wmich.edu. If you don't remember, just go to Western Michigan University and you can find it there.
This isn't a question, but a real quick plug for any of you who have kids, especially if they're teenagers right now. In conjunction with this, they have the science camp for kids with autism, and this is the second year my son is doing it. And you talk about not making them fit into our world, but work with them. The science camp is run by someone who has autism, a doctoral student, and the very first day he went through what's great about having autism, why you're different. Here's some famous people with autism. And my son came away from that the first year feeling proud for the first time because he fit into a group, because he was special in a good way. And so I'm plugging that. Your kids, when they're old enough, getting into a place where they are accepted, it's a really wonderful thing.
How could people access that camp?
Look it up. This year it was called Escape from Mars. It should be on the internet, but I think they had it should be in with some of the conference materials online, I would think. And it was, last year was the inaugural year. It was 2 days. This year they expanded it to 4 days. The kids don't stay overnight. They stay with their parents, so we have to be here. But since it's in conjunction with the conference, it works out really nicely. Fantastic stuff.
Good stuff. Well, thanks everybody. I've enjoyed it.
All right, thank you everyone, and thank you Dr. Poling for giving us so much to talk about. So the session number was 19, and the code is SAT789. SAT789. Thank you.